Okay, let's talk about migraine. By the way, I actually have a little bit of I cross the UCLA, USC, county UCLA boundary. I'm actually a professor of medicine at David Geffen School of Medicine at UCLA. It's no longer the School of Medicine at UCLA. It's the David Geffen School of Medicine at UCLA. But I'm also a county employee. I've worked in the county for 20 years. My background, so that you know, is I'm board certified and residency trained in both internal medicine and emergency medicine. And that wasn't on purpose. That's because I started out in internal medicine and discovered about halfway through that I really didn't like it. Finished because I felt committed to the residency that I had committed to, and then went back and did a second residency at Harbor, and I haven't been able to cut the cord since. Working in the county here in Los Angeles is really a very fun, very challenging thing to do, and it's completely fun. Welcome to those of you who are not from Los Angeles. Welcome. It does get sunny. It will this afternoon. It'll be a gorgeous day today, later. It's actually kind of, you're in an interesting part of town. All right, let's talk about migraines. I think it starts on page 1. Is this the very beginning one? Excellent. First of all, this is like not terribly personal information. How many of you have ever had a migraine? I have. I had them as a kid, and actually as an adult, I have basically homonymous hemianopsic migraines. I get no headache, I just lose half my field of vision. We'll talk about that and what that means as far as medications and things are concerned later, but it's important to understand that not all migraines are created the same. Overall, those of us that work in the emergency department, we see, well, about 2 years ago, we saw 114 million visits in the United States to the emergency department. Of course, that was with 4,000 ERs instead of 5,000. We're shrinking our number of ERs, we're increasing our number of patients. And of that 114 million patients, 1 million were for headaches. Okay, that's just what came to the emergency department. That's not what's being seen in primary care kind of offices. So headache is an enormous complaint. Headaches kind of are divided into two groups. One is the kill you headache, the lethal headache, which fortunately is only 1% of all headaches, but up to 10% can have a bad outcome. 1% are potential killers, meaning that 90% are what they call benign headaches. And that includes the whole spectrum from tension headaches to cluster headaches to migraines. And we're going to talk mainly about migraines here. But the beginning part of this section, what I want to really talk about in this is we'll talk about migraines and how to treat them and how to approach them, but one of the things we do not want to miss, especially those of us that work front lines in the emergency department, is the killer headaches. Let me give you some data. The prevalence rate among females is 18% for migraine headaches and 7% in males. So basically you have 1 in 8 women, 1 in 7 women that will have a migraine problem in their lifetime, and 1 in about 12 men will have a migraine problem in their lifetime. Out there walking and talking, in fact, all of you in this room, 1 or 2 of you has a Berry aneurysm right now. There is an overlap in the Venn diagrams of those two groups of patients. Migraine patients are just as likely to have that 1 to 2% risk of a Berry aneurysm as are non-migraine patients. The whole first couple of abstracts here, abstracts 1, 2, and then 3 as well, look at the killer headaches. Before you jump into, oh, it's just another migraine, each and every time you should convince yourself that it's not the bad headache that's going to kill somebody. This is really important. This is extremely important. The misdiagnosis rate of subarachnoid hemorrhage ranges from 13 to 25%. Now, the good news is that's better than it used to be. Okay, it used to be between 30 and 40%. We're better than we know now the kinds of things to think about, but we still miss it. And the people we miss it in are the people that are walking, talking, sitting, chatting, saying, I have a terrible headache, and yeah, I have migraines. It's very easy to fall into the trap of, oh, it's just another migraine. The thing that helps you with subarachnoid hemorrhage in the first 2 abstracts, by the way, misdiagnosis as far as a subarachnoid person, the misdiagnosis rate of that being called a migraine is about 9 to 13% of the time. So when we miss it, we call it a migraine 9 to 13% of the time. How do you know? A couple of things. Migraines have a pattern for any individual patient. And it is really important to ask every single, I don't care if you've seen that same person 30 times and you want to slap them. What are you doing here again? You have to ask every single time, is this exactly like your migraines? Is there anything different about this migraine compared to your other migraines? Because it's crucially important to get that information from them. If they say, actually, you know, I always get a really bad headache, but this time I'm throwing up a lot. And I don't usually throw up. Or my migraines usually come on over several hours. This one came on really suddenly. Those are warnings to you that this may not be the migraine this time. This may be the killer headache this time. And the onus is on you to make that decision, to actually get that information. Subarachnoids classically are abrupt in onset and maximal at onset. They can go away, though. And abstract number 3 looks at this. One of the things I want to warn you strongly about, and there are multiple case studies in the literature that look at response to medication of a headache and whether you then feel better about that headache. For instance, this one looks at triptans. Abstract number 3 looks at triptans, where you would think triptans are specific to migraine kind of things. Well, they're not necessarily. There are papers out there that look at narcotic response, headache response to narcotics, headache response to opioids, headache response to triptans is this paper. Again, they're case reports, but these are people whose headaches went totally away with the migraine medicine. The doctors felt fine that they were, it's no big deal, it must have been a migraine, and it wasn't. It was the subarachnoid. Never let a response to medicines convince you it's not a subarachnoid hemorrhage. If it was abrupt in onset, maximal at onset, it's just different from their other headaches, I don't care if it responds to pain meds. It's the history that helps you decide if it's a subarachnoid or not. And again, the whole point of this is we see a boatload of migraines. Every once in a while, in that big group of patients is going to be the subarachnoid hemorrhage patient, and know that there is an overlap of those two groups. And don't miss it, I've seen probably half a dozen now of chronic migraineurs that come in and somebody was vigilant enough to pay attention, do the workup, and found the subarachnoid hemorrhage. So that's the scoop on that. Now the whole next set of papers basically bash us. We who work in the emergency department are terrible, horrible people when we treat migraines because we treat them wrong. The next set of abstracts kind of looks at variable practices in treating pain in headache patients, primarily migraine patients, but a whole bunch of different kinds of patients. Abstract 4 and 5 look at actually quite a few patients. Abstract number 5 is 500 migraine patients that were seen in the emergency department. What this paper did is that they found when they looked at how we treated them, those of us that work in ED, when they looked at our treatment, they found that basically 60% of those patients got opioids. Now that is not considered the primary first-line medicine for migraine headaches. And this paper basically says, what's wrong with you people? Why are you people using these opioids? Do you not know the literature? Do you not know how to treat migraine patients? What I submit to you is that I don't think that if you look at studies on how to treat migraine pain, that all migraine patients are the same. I think the patients that come to the emergency department are a potentially different group of patients than those that are followed chronically long-term in a doctor's office. We deal with the person who hasn't gotten, they've either already treated themselves this time around and it's not working, or they don't have a primary care doctor where they can be seen, or they are primed to expect certain kinds of medicines. I don't think it's necessarily saying that we are terrible people in as often as we use opioids. And the numbers out there are between 30 and 60% of people that come to an emergency department get an opioid for their headache. I don't think it means that we're cretins. I think it means that the patient expectations, our sort of agendas are a little different than they may be in a primary care office. That being said, I still think we can probably do better. I have to admit, I will confess to you, that it is not infrequent that I just say, look, I want you gone. I want you better. What I'm going to do is give you something. We're going to knock out that pain. We're going to send you home. And opioids do work. The problem with opioids is you have a 50% recurrence rate within 24 hours. So I make them feel better when I see them. I can get them out an hour earlier. One of the papers in here looks at this. You could basically get them out an hour earlier as well. So pushing people through the system is helpful. But it's not really the best way to approach it. If you can, and someone isn't primed for opioids, where they don't come in and say, I'm allergic to everything but that D drug. What is that D drug? Well, we're a Demerol-free ER. Well, the other D drug, that Dilaudid stuff, I'm not allergic to that one. If you're going to play the game, sometimes it's just more expeditious to bite the bullet and give them what they want and send them on their way. I think, though, if you can, it is not the best practice. So it's up to you to kind of decide how you want to approach this, but it really isn't the best practice. So overall, if you have to default to opioids, it's fine, but know that it's not the best way to go. So what is the best way to go? The whole next set of abstracts, all the rest of this section, this particular chapter deals with drugs, the individual drugs. The next set looks at triptans. Now, triptans, when they came out, were sort of the prophylactic medicine. Ooh, it's coming. I have my aura. Let me take the triptan, and it will make it go away. It actually is, this group of medicines can work even in the emergency setting. It is not just a prophylactic medicine. It's actually a treatment medicine, and some of them work just fine for us in the acute setting as well. There are some downsides, though, to triptans. Don't give me a triptan. Okay, my kind of migraine, where I get homonymous hemianopsia, you don't want to give me a triptan. Don't give somebody with coronary artery disease a triptan. Don't give somebody with a hemiplegic migraine a triptan. They're vasoconstrictive drugs. Somebody who has hard neurologic findings from the vasoconstriction of their migraine, you can actually stroke them out by giving these meds. Same thing with DHE, which is coming later, but you do not want to give triptans in that group. And if you have somebody who has migraines without focal neurologic findings, but they have significant coronary artery disease or known significant cerebrovascular disease, it's a class of drugs you shouldn't use. The downsides are there. And they work. We'll talk about that in a second as well. But just know that there are certain patients in whom you shouldn't be using these agents. Okay, so in your armamentarium of things, they're absolutely there, but no, there's a certain group of patients you shouldn't even touch them. Now, is one triptan better than another? The whole next set of abstracts looks at this, and if you want one paper to beat yourself to death with over triptans, pick number 13. It's a meta-analysis that looks at 24,000 patients, 53 randomized controlled trials, looking at all the kinds of triptans out there, and there's lots of them, lots of triptans out there. The bottom line is there really probably isn't one triptan that's a whole lot better than another. You get certain things, though, from specific triptans. For instance, sumatriptan, what you get from that is a little bit of a delay in onset, but a longer duration of action, okay, versus rizatriptan, which is Maxalt, that actually kicks in pretty quickly. It just doesn't last quite as long as sumatriptan. Sumatriptan has less recurrence rate than rizatriptan, but probably not significantly so. They both work. And the bottom line is triptans do work. You can kind of pick which one you want. I honestly think you should pick it if you use them, pick it on cost. Okay, these things they are huge. than giving a placebo. And there are two papers in here that compare them head to head. Metoclopramide is probably your second-line drug to choose if you can choose just from anything out there. Compazine is probably first, metoclopramide is second. They both work quite well. You just get a little bit better pain sort of control with the compazine than you do with the metoclopramide. Now, how about Droperidol? Any of you guys still use Droperidol? They won't even let us use it anymore. I mean, can anybody use it? We can have a moment of silence for Droperidol. I really miss it. It was such a great drug. It calmed down people that were crazy. It took nausea away from people, and it had that one wonderful component. If you could distill it out, if I could take the molecule, whatever part of that molecule makes people say, okay, I gotta go. I'm out of here. If I could purify that and inject it at the time of discharge for people in the ER, it's time for you to go. See ya. Yeah. Unfortunately, we can't use it at all anymore. Is it good for migraines? Yes, it's great for migraines. It's a double whammy drug, takes care of the nausea. It really is good for migraines. Unfortunately, most of us can't use it anymore. And rather than waste time on that, we'll just all be very sad for a second, and we'll skip Droperidol. Magnesium. Those of you who've been to abstracts courses before or who listen to the abstracts tapes know that Rick Bucata, who's the father of the abstracts, adores magnesium. I mean, I'm sure he would like to put it in a cream and smear it on his skin. He would like to put it in the water. He loves, and it does work for some stuff. I think what happened when Rick saw paper number 27 is he must have gotten so excited. Actually, number 27 is a paper that said, magnesium works for migraines. And I'm sure Rick just read this and went, woohoo, yay, it works for migraines too. Fabulous. The person who wrote this paper is a big proponent of magnesium as well, did a non-randomized, non-controlled trial, 40 patients, and said, wow, magnesium helps migraines. Unfortunately, somebody did abstract 28, 29, and 30, and they all said, not so much. It really doesn't work. So for migraines, we will just have to put magnesium back in the crash cart, and it doesn't really work for migraines, so we'll skip that. How about intranasal lidocaine? Abstracts 31, 32 look at intranasal lidocaine. Are you guys seeing less cluster headaches than you used to? Those of you who have been practicing for a while. We used to see a lot of cluster headaches. And I'm not sure if people have changed or I'm just not seeing as many cluster headaches. We used to use intranasal lidocaine for clusters all the time. Intranasal lidocaine and oxygen seem to work quite well for cluster headaches. The DHE was sort of the third line thing. It turns out that intranasal lidocaine may have some efficacy in migraines as well. And this is kind of one of those things you just throw it in your pot of kind of tricks, things you can pull out of your bag of tricks. You basically use 4% lidocaine. You take a half a cc. You take the patient, you lie them with the side of their headache down. You drip it into their nostril, and you let it sit there. What it's doing, by the way, is it's coating the sphenopalatine ganglion, which is felt to be a gatekeeper for pain that is transmitted sort of from your head to your sort of, I'm aware of having pain. The theory is it breaks that, it's a gatekeeper, breaks that sort of communication. That can work. The efficacy, it's a teeny study. It's well, not teeny, 81 patients in this particular study. They did have an improvement of pain. It went from a pain scale of 6 to a pain scale of 4. So you get a little bit from it. And it might be something to consider. I wouldn't go there first line, but it's kind of something to throw in there. Abstract number 33 and 34 and 35. Look at basically what they say are, we need studies in children. Migraines happen in kids, no question. Migraines tend to happen around puberty, is where they're the most common in children. And unfortunately, no one's done great studies at looking at the way to treat migraines in children. There really aren't a lot of good sort of randomized controlled trials. The best paper, if you want to kind of get a quick overview of it, is 35. It's a summary paper. Basically, they pulled together what randomized controlled trials in children had been done and said, well, actually, here are the things that have been studied and we know work. Tylenol, ibuprofen, intranasal sumatriptan, and basically compazine. Okay, those work in kids. And I don't think that at least teenage kids are, maybe they're really different. Some people say they're aliens, that they're actually not even humans at all at that phase in their lives, but I don't think they're that different from adults. They're basically just hormonally challenged adults. And I think that to use compazine is absolutely fine. We just don't have a lot of great data to say what's great. Now, at the end of this, how many of you, when you treat a migraine patient, give them a dose of steroids on their way out the door? Anybody do that? There is some evidence. There's a paper in here, abstract 36 is in here. There's a little bit of evidence out there that giving steroids as part of your concoction for treating migraines will decrease the relapse rate. Jim Ducharme, who's one of our faculty members for this course, has just published a fabulous book on pain management in the emergency department for basically everything and anything out there. And it's a very, very evidence-based book. What they recommend in that particular text for migraine patients is whatever you use as your primary drug, and their recommendation is compazine. Okay, 70 to 90% efficacy, relapse rate less than about 15%. That's the drug they recommend, and they recommend adding on steroids. Because what that will do is take your 10 to 15% recurrence rate and drop it to single digits. So you have somebody who you will actually get through that episode of migraine, decreasing the risk of a recurrence. This particular paper isn't the one to use to prove that to you, though. What they used in this paper was 24 milligrams of IV Decadron in these migraine patients. I don't think these patients cared they had a headache. They were so wired for a week, they repainted their entire house. I don't think they even cared that they had a headache. The reality is the dose you need for this, if you do it, is 10 milligrams of Decadron if you decide to use Decadron, or better yet, use prednisone 50 milligrams PO 2 days in a row. Okay, give them 50 milligrams PO now, have them take 50 milligrams tomorrow. You've already given them the IV compazine, their headache's gone away or gotten much better, you send them on their way. That seems to work the best. So if you want to summarize the approach to migraine, don't miss the bad stuff. So be patient with that person you want to slap, get a really good history, and document clearly this migraine. There are no characteristics of this migraine different for this patient than any other migraine in the past. If there is something that's different, it's a worse headache than they usually get. They have more nausea. It came on abruptly. Something's different. Step back and rethink it so you don't miss the bad headache. When you treat it, probably the first line is compazine. Okay. Second line is metoclopramide. The DHE and triptans work, but there's some downside. The vasoconstriction can be a problem with that. If you use compazine particularly, you might want to use cogentin with it. Opioids are fine. Probably best not to use it first line if you can avoid it. And if you use it, they'll work, but the relapse rate is high. If you want to decrease the relapse rate, overall, you can add a steroid kind of as a bonus on the end as they go out the door. That's it.